is Hannah Merculis. I'm a student physical therapist assistant at Jeff State, and today I'm going to be talking to you about some common pulmonary pathologies. So here listed I have a couple of pulmonary pathologies that you might see throughout your career, and specifically I'm going to be discussing with you COPD, chronic bronchitis, emphysema, asthma, and restrictive lung disease. So for some statistics, COPD, asthma, acute lower respiratory tract infections, TB, and lung cancer are among the most common and severe illnesses and death worldwide. Estimated about 65 million people have moderate to severe COPD, and of those, 3 million people die each year. This making the fourth leading cause of death in the United States and worldwide. According to the CDC in 2018, approximately 9 million people were diagnosed with chronic bronchitis and 3.8 million people were diagnosed with emphysema. So there are two types of lung diseases, obstructive versus restrictive. Obstructive, we're going to be looking at the decreased expiratory volumes, and the restrictive lung disease, we're going to be looking at inhalation issues. So restrictive lung disease, like I said, they're going to have issues with decreased in total lung capacity. They're going to have issues taking in a deep breath during inhalation. Patients with COPD or chronic pulmonary disease, this is one of your most common pulmonary disorders. This is where it's affected the process of breathing out. And so the three cardinal signs for this pathology will be dyspnea, chronic cough, as well as sputum production. And some of the minor or less common symptoms would be wheezing, as well as chest tightness. So some risk factors for COPD will always include smoking across the board. You can also have a recurrent infection, air pollutants, or your social economic status can affect this as well. Here's just a picture of a healthy lung versus a patient with a COPD lung. You can obviously tell the difference in color. And I also posted this picture to demonstrate what's going on inside the lung at the bronchial level and the alveoli level. So treatment of COPD is a multifaceted approach. So a lot goes into it. We're looking, or not us specifically, but doctors are looking at their dietary needs, if they're lacking any kind of vitamins or anything to help them. They also want to address their smoking issue to be able to quit and have access to the tools that you need to quit that. And then they also will be on some sort of medication to help with their airway restriction or obstruction, with oral or inhaled bronchodilators, as well as any kind of anti-inflammatory, antihistamines, or antibiotics to help with this process. Next, the big three COPD, the chronic asthma, chronic bronchitis, and the emphysema will be addressed. Asthma, defined as bronchial tubes with sticky secretions within the tube. Most people are going to experience tight airways or inflamed airways. And some of the risk factors for asthma will be exercise-induced asthma, what kind of weather they're having or what kind of season we're in, for pollen levels, as well as food allergies or dust or mold allergies, and always smoking is going to contribute. So blue bloaters is the term used for patients with chronic bronchitis because they're going to have a cyanotic or blue dusky tint to them. They're going to have a chronic cough and chronic sputum production, as well as an increased respiratory rate. So, like I said before, some of the risk factors for patients with chronic bronchitis will include their environmental factors, occupational hazards or pollutants, as well as smokers. Some of the symptoms and signs will be daily productive cough, shortness of breath, and wheezing. And it's important to know that to be diagnosed with chronic bronchitis, you have to have a productive cough for at least 3 months per year for a consecutive of 2 years. Next, we have the pink puffers, also a term used for patients with emphysema, and emphysema is going to be affecting the alveoli in the lungs. So the risk factors, also smoking is going to be the number one cause, and it's also accompanied with chronic bronchitis. So for physical therapy purposes, we're going to be addressing the aerobic capacity of these patients, make sure we're monitoring their vital signs and how out of breath they get, and modify that as we go. We want to address their strength, both upper and lower, lower extremity training, as well as the accessory muscles used for respiratory. We also want to use some potential breathing techniques for especially patients with COPD. We can use the pursed lip technique where they breathe in and then slowly breathe out with a pursed lip to help control that, as well as diaphragmatic breathing. And then we can also use a technique for secretion removal, and that includes postural drainage or percussion vibration techniques. So equipment used, a patient will most likely have some sort of volume incentive spirometer, usually prescribed by the doctor, but we're going to be using a stethoscope typically to perform auscultations. And auscultations are just a technique or skill used to determine how well the patient is breathing through the stethoscope. So we're going to be looking for some breath sounds, whether it's abnormal, normal, and some of the terms down here are vesicular, bronchial, decreased breath sounds, or adventitious sounds, in which those are termed crackling or wheezing. And you're most likely going to hear a crackling sound in patients with COPD, chronic bronchitis, and then your patients who have asthma will have the wheezing sound. And then here's just a list of possible locations for auscultations. Make sure you're reading the patient history to know where to perform these auscultations. You can perform on the front, the back, and the side, just to have the better view of, or the better sound quality. And then here's my video. All right, so I'm going to perform auscultations to this patient. You're going to stick the stethoscope in your ear and then put the bigger side on the patient's skin. I'm just going to perform auscultations to the anterior side of the upper lobe. And so you're going to go right below the clavicle on each side, like so. This can be a little cold. And then you're going to ask the patient to breathe in through their mouth and quietly exhale. Good. I'm going to do it to the other side. Sorry, it's a little cold. Do the same thing. Breathe in through your mouth and quietly exhale. Very good. All right. Thank you. And then here's my references. Let me know if you have any questions or concerns from this post, and I'll get back to you. Thanks.